Thanks for coming. I'm Dan Fein. I'm in the Pulmonary division. We're going to talk about patient-ventilator interactions. Okay, so first couple slides about how this is a difficult topic. I actually prepared this lecture first before I went on a trip to Argentina, and all I talked about for a couple weeks was waveforms, was ventilator waveforms, and my wife was really sick of it, and she was like, "Oh, we'll go to Argentina though," and then like, "You want to talk about waveforms for a few days?" And then we were in the subway in Buenos Aires. I was like, "Oh, look, there's ventilator waveforms." So there's no escaping ventilator waveforms. This is our outline. We'll talk about patient-ventilator interaction, why you should care, the basics of ventilator graphics, my own algorithm that I have not copyrighted, so you can steal to evaluate patient-ventilator interaction, and bedside recognition and management, which would be the meat of the talk. Okay, so what is patient and ventilator interaction? So there's two pumps. There's the ventilator pump, and then there's the patient itself. And the pump of the patient is actually the respiratory muscles. So when these two pumps are in synchrony, this is what we talk about when we talk about ventilator patient synchrony. So the goals of intubating a patient are improving gas exchange, reducing work of breathing, promoting patient comfort, and mostly just that intubating someone in and of itself is not curative. It just kind of gives you time to do all the things that you need to do, like give them antibiotics and bronchodilators and steroids. So the goal is just to do these things here and let your therapies work. When the patient and the ventilator are not synchronous, it's sometimes said to be a tug of war, and you're actually defeating the purpose of why you intubated them in the first place. All right, so does this matter?
75-year-old man with sepsis is intubated for hypotension, altered mental status in the setting of metabolic disturbances. How should this patient's sedation be managed?
So just tell me what you think of the waveforms at the bottom first. There's the pressure and the flow, right?
Right, so the top one is the pressure curve, and the bottom one is the flow. Yeah, the flow curve. So, I mean, the pressure curves are kind of variable. Like, there's some that are.
Yeah, I think that's the main thing to take away from this, right? That in most ventilator modes, the waveforms should look pretty similar. And in some modes, there's two kinds of waveforms, but it's never like each one is different, right? So when you see that, that's an immediate alarm that there's some sort of dysynchrony or something's not right with the patient or the ventilator. All right. So what if with this patient, we'd let him just do all the work? So you guys are aware of this study, the Accurasis study, where they paralyze patients with ARDS for the first 48 hours, and you guys know what they found? So mortality benefit. So why was this though? What was the hypothesis for why this helped?
Ventilator synchrony.
Yes, that was one of the hypotheses for why this helps. Yeah. So this is actually graphics from the editorial by Dr. Swartz. And what they thought was that when there was dysynchrony, you had all the things that we often talk about with why the ventilator can be harmful. So you see the dysynchrony on the left in those graphs. The ventilator and the patient are working at different times. And then this causes barotrauma, value trauma, and adolescent trauma, these injuries that we often talk about. And when that happens, you get the worst one, which is biotrauma up here, right? So you get release from these injuries of all these inflammatory mediators. And why do patients with ARDS often die? What's the number one reason for death? Is it hypoxemia? No, so like it's listed up there, but what's the most common reason?
Multi-organ.
Yeah, exactly. Multi-organism, right? So it's postulated that all these injuries lead to biotrauma, and that will cause organ dysfunction and death. So after paralysis, if we prevent these injuries, you get less biotrauma. That's possibly helpful to the patient. Less multi-organ failure, patients do better. This is the theory, at least. Yeah. So where's the beef? So unfortunately, there's not a lot of literature on patient ventilator synchrony. A lot of it is kind of retrospective and even prospective studies, but nothing really randomized. No one's ever randomized patients to. I'll just say that there's no high quality study showing that this is very important, but this is the data we have. So the three studies I'll show you, this one, they looked at the incidence of ventilator asynchrony and identified associated factors. So 62 patients requiring ventilation. And interestingly, almost a quarter of patients had an asynchrony index greater than 10% of respiratory efforts. So an asynchrony index is just like how many of the breaths were asynchronous out of the denominator is like total breaths. So a quarter of the patients had 10% or more of asynchronous breath as the total breath. And what did they find? So the patients who were asynchronous, so you see the ones in the middle column there, they had more than 10% of their breaths were asynchronous. They had longer duration of mechanical ventilation. They had higher numbers of trachs and higher mortality, right? So just to reemphasize this doesn't mean that if you correct their asynchrony, that you will fix these problems. They won't die less. We don't know that. But it does mean that possibly asynchrony is some sort of marker for bad outcomes. Yeah. So high rates of asynchrony, longer times on mechanical ventilation. So possibly a marker for that. This is a similar study. They looked at this thing called trigger asynchrony that we'll talk about more in a minute. And they assessed for asynchrony in the first week. And a healthy proportion of patients had trigger asynchrony, and they found that patients who had trigger asynchrony were older and more likely to have airways disease. Interestingly enough, too, so of the 19 patients who had trigger asynchrony, only 3 of them were able to come off the ventilator during the study period. So this is kind of all the data together. So what we can see is that asynchrony is common. So these are the percentages, right? So anywhere from like 10% to up to, in this study, 85%, which is fairly insane, of patients had asynchrony. These are the most common types of asynchrony. So interesting enough, before I put together this lecture a few years ago, I always just knew about double triggering, which we'll talk about in a minute. But the most common type of asynchrony that we actually see is mistriggers, which we'll talk about in a second. The patients overall seem to have airway disease as the most common risk factor. And then we just talked about the outcomes. All right, so what are the consequences of patient ventilator asynchrony? So ineffective ventilation, hypoxemia, so all these kinds of parameters that we often look at. But then some of my favorite ones here are distress for family members and others at the bedside, and the worst of all, conflict among team members. So if your patient is asynchronous, they'll have conflict. Yeah, and you don't need that. We don't need to fight with anyone. So okay, so I just told you that asynchrony is probably bad. So what if we just knock the patient completely out, right? Is this going to be good for the patient? What happens when we use heavy sedation for our patients? So you guys know about this study. It was a small study that looked at both brain dead patients and patients who were having resections for lung cancer. And what they did was they just took little pieces of their diaphragm while they were in the OR. And so this is the cases, and these are the controls. So what do you guys think about the difference between the myofibers of the diaphragm here versus here? So that they're atrophied. So these patients, I think, anywhere from 18 to 69 hours of diaphragmatic inactivity. So after the point that they were brain dead, these were taken. So what they showed was that just that amount of time of diaphragmatic inactivity can cause diaphragmatic atrophy. So patients passive on the ventilator for not that long can cause diaphragmatic dysfunction. And then you guys just mentioned these other adverse outcomes from sedation, right? So mortality, delirium, all kinds of bad stuff. Okay, so we just talked about how with patient-ventilator interaction, so this isn't sedation, this is interaction. So if the patient interacts with the ventilator too much, you get excessive work of breathing, possibly dynamic hyperinflation, ventilator-induced lung injury. If they interact too little, then they'll get diaphragmatic atrophy and possibly prolonged mechanical ventilation. So what do we do So this is a quote from Dr. Tobin. Oh, I didn't ask you guys about that picture. The devil and the deep blue sea. You're stuck between two rough places. Yeah. So to navigate a patient's safe passage between the Scylla of excessive patient effort and Charybdis of excessive respiratory muscle rest, we suggest that clinicians carefully titrate ventilator settings and pay close attention to the contour of the airway pressure waveform. So Dr. Tobin postulates that in order to navigate this rough spot, we need to just look at waveforms. Okay, so ventilator graphics. So these are the 4 parameters that we look at in mechanical ventilation for the most part: time, pressure, flow, and volume. And these variables make up scalars and loops. Do you guys know what a scalar is? Scalar is pretty much just time on the bottom, and then one of those other things on the y-axis. And a loop is just, there's no time, it's just combinations of like pressure and flow, or flow and volume. Like a scalar is like in a PFT lab when we do a flow volume, it's a scalar. So for the most part, we're just going to talk about, sorry, that's a loop. That's a loop. We're just going to talk about scalars. So this is an example of a loop. So sometimes we also look at these on the ventilators as well, especially when we're looking at compliance and other parameters. All right, and this is a scalar, just what we're usually looking at. So time here, and then pressure on the y-axis, or flow on the y-axis. So the pressure time scalar can be really helpful. This is probably the most helpful one. We'll go in order of most helpful to least helpful. We look at airway resistance, compliance, and patient effort. Flow, second most helpful. You can, it can be either square, decelerating, or sinusoidal. I haven't really found it that helpful. This kind of just tells you what the mode is, but usually we're looking at decelerating. And then volume. So you guys understand about the volume scalar and how you use it to find an air leak. So you see how the volume goes up, and then it comes down, and when it doesn't go back to baseline, that's indicative of an air leak, the volume being that little divot there labeled as A. So it's most helpful for this purpose. Otherwise, flow and pressure are more helpful. Okay, this is my algorithm. So I think of it like an EKG, in that you just go through it systematically, and you'll never miss asynchrony. 14 steps. So in truth, there's 14 steps, and I made this up, but then I usually just do the first 3 steps. And, I'll do like combinations of the other steps. 14 steps is like kind of a lot to, even for me, who made it up to remember. So I think the first patient is just the first thing is looking at the patient, thinking about, are they comfortable? And then what Eric was doing before, thinking about how many types of breaths are there and how many breaths there should be for that particular mode of ventilation. And then this is the most important part, I think, is just putting your hand on the patient's chest and then watching the waveforms, because you'll be able to gauge their effort. And immediately, if you're looking at, sometimes you can tell what's going on just by looking at the vent, but a lot of times feeling the patient's chest while you're looking at the ventilator, I find, can be really helpful, because you'll be able to see if they're making an effort that's not generating a breath, or if they're double triggering. It'll be immediately apparent when you put your hand on the chest, and then watch also the waveforms at the same time. Okay, and then other things to do that I do in different combinations depending on the patient is just then looking at the pressure time scalar. As we said, this is usually the most useful and important. Determine the CPAP level, determine if the patient's triggering. This is kind of more analogous to EKG, is every patient effort followed by a ventilator delivered breath. So when you have your hand on the patient, every time that their chest is moving to try and breathe is then the ventilator actually doing what the patient wanted them to do. Are there breaths in rapid succession, what we call breath stacking or double triggering? What's the shape of the pressure wave? This we'll talk about this in a minute, but what is this indicative of? But it's also indicative of flow asynchrony or flow starvation, that they're not getting enough flow. Yeah, we'll talk about that more. Does the breath stay above CPAP? So sometimes when they have what we call flow starvation, the whole breath can actually be below the CPAP level, indicating that the ventilator is not really doing any work. It's mostly the patient doing the work. And as we said, the whole point of intubating them is that you're trying to help them out with their breathing, right? And does the patient attempt to cut off or prolong the breath? And we'll talk about how to identify that. And in terms of flow, are they actively expiring? So sometimes we see in these patients with airway disease where the flow will be here, and you'll see the patient actually working to expire before the next breath is delivered. And that could be indicative that their airway mechanics are really impaired. And does expiratory flow return to zero? So 0 here, and you guys can see this expiratory flow does not return to 0, right? And then just with the volume times scalar, again, you can identify leaks based on looking at the volume times scalar and seeing here that it doesn't return to baseline. Okay, bedside recognition and management. So the 3 different, or really the 4 different times when you can have asynchrony are these times. So trigger, which is also called initiation, and I have these fun graphics to help you remember. Trigger. Pressurization, which is delivery of the breath, or targeting, and then cycling, bicycle. Get it? Cycling is the end of the breath, and then expiration also, as we talked about, you can have asynchrony during expiration. Okay. What do you think about this? So he has airways disease, and what do you think is going on? Looking at the breath. So these are actually, it's still tachypnic, but these are normally delivery breaths until here. Something happens here, and here, and here. So it's kind of tough without actually looking at the patient. But I
think he's having like a pause.
Yeah, a pause. But actually, if we looked at him, we might see that he's actually trying to initiate a breath, but can't. Yeah. See, so what's this called? Yeah, missed trigger. A missed trigger. And as we talk about, this is actually the most common kind of asynchrony rather than breath stacking. But you can see how it could be easily missed, right? It could be easily go under the radar because it's not as dramatic as the double trigger. Double trigger is like, hey, here I am. Okay. So problems you can have during triggering. So yeah, a missed trigger or this. What is IE stand for? Yeah, inspiratory effort. Yeah, exactly. Saying there's some sort of change in the flow, but no actual ventilator breath is initiated. So the problem can either be that there is an insensitive trigger, so the ventilator is set incorrectly, or intrinsic PEEP. So do you guys understand what intrinsic PEEP is? Just that the patient's obstructed, and when they breathe in, then they get something called dynamic hyperinflation, but they're not able to fully expire. You develop intrinsic, and it's different than the P4 that you can apply to a patient. Okay, so the solution, the best thing to do is improve airway mechanics, because that is easier said than done. The other things to do are change the ventilator in terms of decreasing the I to E ratio, decreasing the minute ventilation, or increasing applied circuit PEEP. We'll talk about that more in a minute. And then you can also change the trigger. So if in the patients we looked at, you can decrease the trigger sensitivity and he'll be more able to initiate a breath. So this is a very complicated algorithm for how to decrease missed triggers, but the main thing is just that what they recommend is that you go up by an increment of about 1 centimeter of water from PEEP to 5 until you find that the patient's no longer missing triggers. So why is this? Okay, so the patient is breathing all the way up here, right? And they're trying to drop their pressure to initiate a breath, but they can't generate enough flow because in order to generate flow, they have to overcome this big pressure difference here. So this is the PEEP we're giving them, and this is actually their intrinsic PEEP or their auto PEEP here. So in order to make this difference less and for them to be able to generate a flow, we actually have to increase the PEEP to here. And this way, they're able to breathe, they're able to use less effort, and they're able to generate the breath more effectively and trigger the ventilator. But so why isn't going up on the PEEP actually increasing the airway pressure as a whole and dangerous for the patient? So actually, Dr. Tobin wrote this editorial where he said it's analogous to a waterfall. So this difference here is the overall difference between the This is the applied PEEP and this is the intrinsic PEEP, this difference that we were talking about, that's where the patient has to overcome the breath. As long as you just raise this level here to where this pressure point is before, the total PEEP in the system won't actually increase and it won't be dangerous to the patient. It's only when you give your intrinsic PEEP above the, only when you give your applied PEEP above the intrinsic PEEP that you increase the total pressure in the system and that you possibly can cause harm to the patient. Okay, auto triggering. Consecutive, it's rhythmic, and it's rapid, right? So it's probably that something in the patient or something in the circuit is triggering the ventilator to fire like that, right? And in this case, they're showing you the EKG is probably the heart rate. So yeah. Okay. So it's frequent rhythmic beats caused by drops in airway pressure below the threshold to initiate a breath or inspiratory flow, exceeding the flow triggering threshold. And it's not related to the patient. So I had a similar case like this. So I was a fellow actually, and the ventilator was set at 12 breaths a minute, and I saw the patient was actually over breathing the ventilator, but they actually weren't. When I went over to the patient and looked at them, my hand on them, they actually weren't making any ventilator. They weren't making any breathing efforts. So I went to investigate further, and when I put my hand on the patient's chest, it was actually a patient with cardiomyopathy, and I noticed that the precordium was pretty dynamic, and every time I felt a heartbeat on the chest, you could see those little perturbations on the flow waveform. So there was some sort of dynamic cardiac activity that was actually triggering the ventilator. So auto-triggering delivery of a mechanical breath in the absence of clear contractions of respiratory muscles. And you guys just mentioned problems in the circuit like tube compensation or cardiac oscillations. So you can clean the tube, fix the leak, or change the trigger sensitivity, or as you mentioned, change it to a different type of trigger. Okay. So the breaths look mostly uniform, but then those first breaths there, what is that called? Yeah, breath stacking or double trigger. Yeah. So there's these two rapid breaths that come consecutively. And so the definition that I find fairly difficult is two consecutive inspirations with an interval of less than 1/2 the mean inspiratory time. So luckily, we always kind of, when we see this, we kind of know it, and we don't have to think about the definition too much. So it can result in high delivered tidal volumes, intrinsic PEEP, and theoretically acute lung injury. No one's ever really proven that this takes place, but we know that low tidal volumes are bad in general for our patients, and we know that when these two breaths are delivered in rapid succession, that the exhale tidal volume is certainly usually double what we intended to be, right? So what is the problem? Often that respiratory drive is high, and that we're not giving the patient enough on the ventilator. So a lot of times people talk about this neural TI versus ventilator TI, and that's the inspiratory time that we set on the ventilator versus what the brain of the patient is thinking that they want. And so this is another esophageal waveform. And you guys can see that there's a breath initiated, the breath is cycled off, but then the patient is still inspiring. They're like, oh, my body's telling me I need more. Either, I'm acidemic, or I just have more hunger for air than you're actually giving me. So what can we do? So we'll go through a few of these in the drawbacks and the pros to each of them, okay? So you can change the pressure support, prolong inspiratory time, increase sedation, or increase tidal volume. So what happens when you change the pressure support? Yeah, and subsequently the tidal volumes will go up, right? So you'll likely decrease double triggering, but it might actually be harmful to your patient. So not so good. I found the best results from changing the inspiratory time, either from just changing the IDE ratio or changing the flow. And some patients I go down on the flow, some I go up, and often this helps. Increasing sedation, which we'll talk about in a minute. Increasing tidal volume, obviously not ideal either, but just theoretically can decrease double triggering. So this is an article that was fairly interesting. They came up with an algorithm for how to decrease breath stacking and double triggering, and then they looked to see how often their algorithm worked versus other modalities. So pretty much they switched to pressure support. If that didn't work, they just changed the inspiratory time. And if that didn't work, then they sedated. So as we said, switching pressure support can be helpful, but it may actually be harmful to your patient. It may be helpful to decrease double triggering, but it may cause further lung injury. So this is maybe the most interesting slide of the lecture. So if you've been sleeping, wake up. So this is the pre and the post. So if you didn't do anything, no surprise, nothing really changed in the amount of double triggering that happened. If you sedated, some people got better, some people got worse. But overall, the kind of gestalt is that there wasn't much of a change. But then if you did their ventilator changes, overall the double triggering certainly seems to have a trend towards decreasing. So this is just an example of changing to pressure support. You guys can see all the double trigger breaths here, then they change to pressure support, and they're all uniform. It looks a lot better, but we don't know what the title line is.
You can see what happened. That actually shows you what the other line's going on.
Oh yeah, exactly. Yeah, that's a really good point. So here you see the volume waveform, and then the title line.
And then some are okay, but then that last one breaks them off.
Yeah, that looks terrible.
You have no control.
Yeah, no good. I won't read the whole thing. Just look at the waveform, and then which one of the following adjustments to mechanical ventilation settings is most effective to relieve air hunger and work of breathing? What do you guys think of the waveforms? Are they different or the same? Yeah, they're different. And we talked about this phenomenon of like a scooped waveform, right? Is that perhaps what they look like?
Yeah.
Some of them are scooped out. And what is this indicative of? What's that?
Air hunger.
Yeah, air hunger, or what we call flow starvation, right? So the answer would be A, increased flow rate, yeah. Okay, so this is all about gas delivery. So this is a picture I showed you guys before, but I actually had a patient who I took care of where this was their waveforms, and you actually couldn't tell that they were working very hard. What do you guys think of these waveforms here? The pressure waveform. Is it staying above CPAP? Yeah, it's like completely negative, right? Yeah. So the patient's on positive pressure ventilation, but actually they're breathing like completely negative pressure. So they're making an enormous effort to breathe. And we don't see that infrequently. So yeah, this patient had really severe flow starvation. So often what we say, so this is like a more normal breath. And then this scooped out area here is what we commonly see in flow starvation. And this area in between is what is often called patient effort. And it can look like this, very subtle, or it can be more so, or then more so what I saw with our patient, where it's almost completely negative. We're not negative here, but it's in the wrong direction. So the problem is that the flow is inadequate to meet patient needs, and the solution, you can increase flow, or you can change to pressure-targeted breaths with variable flow, and that'll often fix the problem. So in this patient, I changed the flow. I also went up on the tidal volume very briefly, just to kind of see if it would work. Don't worry, I went back down on the tidal volume after. But then, as you can see, the pressure waveforms, they got completely better. All right, so problems during breath termination. What do you guys think of these? So I'm showing you the esophageal pressure here too, right? So this is negative intrathoracic pressure. So what do you think is going on? This is the airway pressure here.
Patient is trying to breathe on a ventilator.
Yeah, so they're making a negative effort here, a negative, they're creating negative intrathoracic pressure, but then their intrathoracic pressure is rapidly going up at the end of the breath, right? So they're actually trying to turn the breath off. They're breathing in, but then before the ventilator is done, they're actually trying to breathe out. They're like, I'm done this, I'm done breathing, but the ventilator is still delivering the breath. So the machine inspiratory time is longer than the neural inspiratory time. So the patient wants less breath, they try and turn it off, and there's this elevation of airway pressure at the end of inhalation. That's what we see here. So the solution is change flow, change inspiratory time, decrease tidal volume, and you can change the flow cycle setting. I don't know, I haven't done that a whole lot. All right, this is the last one. So what do you guys think's going on here?
The set rate is too low. Patients acidotic trying to blow up CO2, they need a higher rate on the ventilator.
Yeah. And what we see here is this is abnormal, right? So there's flow cycling here. So and also the end of the pressure waveform here. You guys can see as the flow is abnormal here, it almost looks like this pressure wave is being pulled down, right? So here it's that the machine inspiratory time is less than what the brain wants it to be. So you guys can see the esophageal pressure here. So it's similar to double triggering, and that the patient wants more breath. So the machine is cycling off, but the patient's esophageal pressure remains negative. They still want more breath. So they're actually pulling the pressure wave down. And then you see in the flow wave, the pressure wave here, and you can see in the flow wave that you get this kind of undulation. Okay, so you can change the flow, change the inspiratory time, increase pedal volume, which we usually don't want to do, or change the flow cycle setting. Okay, key points. Patient ventilator asynchrony is a common and under-recognized phenomenon. There's a physiologic basis for why patient ventilator asynchrony can be harmful. It's a marker of poor prognosis. You can possibly fix double triggering with pressure support and increasing inspiratory time. We know as we talked about, the downsides of changing pressure support to pressure support, though, that your tidal volumes will go up. And that further research is needed to address if this is actually helpful, these interventions that we're doing. We don't really know. We just know it's common and associated with bad outcomes, but we're not sure if the interventions we're making are actually helpful. Interestingly, this guy I went to med school with, as part of the ROSE study, the recent paralytic study, he did a sub-study where he actually monitored the waveforms of patients getting paralytics and not. And I don't even know if you looked at the data yet, but we're going to have a little more of an idea of whether paralytics are helpful in terms of the waveform aspect. All right, thanks.
Thank you.